panel here needs absolutely no introduction, but I will still go ahead with the formalities. We have Dr. Chandrakant Laharia, is an epidemiologist and a health system specialist. We have Dr. Randeep Guleria, he's the former director of the All India Institute of Medical Sciences. He's now with Medanta. We have Dr. Puneet Mishra, Professor Community Medicine at AIIMS, and of course, Dr. Soumya Swaminathan, who is the former chief scientist of WHO. We take great pride, ma'am, in everything that you have accomplished, and thank you so much for being here. I'll just begin by saying that Dr. Laharia and Dr. Guleria here in their book, Till We Win the Fight Against the COVID-19 Pandemic, said that this is perhaps one of those opportunities that has the potential to transform the healthcare infrastructure, the healthcare systems of India. Dr. Swaminathan, if I can begin by asking you, to what extent do you think that has happened?
Thank you so much, and it's lovely to be on this panel with such distinguished other experts. I think what we realized during the pandemic is a couple of things. First is that no country was prepared, really. So I don't think any country was in a position to say they did well. Of course, some did better than others, but each one had certain gaps and certain weaknesses which need to be filled. India did very well on some counts, like the vaccination program, the initial response, which was taking a very precautionary approach and things like that. But then we did realize especially during the Delta wave, when there was a huge number of people who got sick all at the same time, that our health facilities could not cope with that kind of massive burden which came all of a sudden. And I remember from the WHO at that time, countries started recognizing the importance of oxygen, something so basic and life-saving. You would expect that every health facility would have oxygen, but when we looked at countries like Somalia, many countries, we found that the health facilities had no oxygen. So even before the pandemic, little children with pneumonia or elderly people who needed oxygen would not get it. And what the pandemic did was open the eyes of everyone to the importance of something as basic as oxygen, a life-saving drug. So I think there were those problems, no doubt. But I think a lot has happened since then to prepare, and it's a process. Yes. So I don't think that we go from 0 to 100 right away.
Yes.
But there's been a considerable amount of progress.
We've all been through a phase until very recently where we've almost spoken about COVID in the past tense. But with this JN1 variant, and you've been speaking to us about it, how concerned should we be?
So I just want to repeat what Dr. Tedros said when he declared the end of the public health emergency in the middle of 2023, and everyone heaved a sigh of relief, but he had went on to add, saying that this does not mean it's no longer a global health threat. It's just that it's not an emergency anymore because we have the tools and things to deal with it. So I think it continues to be a threat, primarily because it's still a relatively new virus in the sense that it only got introduced into the world 4 years ago, to human beings rather. And so we're still learning, we're still adapting. Of course, our immune systems are much better primed now because of the previous infections and the vaccinations that most of us have had. But still the virus is evolving very rapidly. And so what we are seeing today is a variant which is from the family of Omicron, but it's been able to acquire another mutation, which is helping it to outcompete its previous brothers and sisters. So it is today the most transmissible, not necessarily more severe.
More transmissible.
More transmissible. So that's why it's transmitting, spreading more quickly. It's becoming the dominant variant globally.
Right. Dr. Guleria, if I can bring you in, just speaking of JN1, because this has literally dominated national headlines over the last couple of days, I want to ask you, we've all been double vaccinated. We were not triple vaccinated like certain other nations did. How efficacious are our vaccines against this variant and any potential variant to come?
So two parts. One is, as far as the efficacy of the vaccine is concerned against the new emerging variants, I don't think we have enough data to really say one way or the other. But if you look at the fact that we also have had significant amount of natural infection because of the sublineages of Omicron, it's quite likely that as a population we have a good amount of immunity, and it does seem that some degree of immunity would be there based on the vaccine that we took, which was basically based on the Wuhan strain. So it's likely that we have immunity, both because of natural infection and because of some degree of immunity because of the original strain. But if we move forward in terms of revaccination, then like we do in influenza, that we have a flu shot every year which contains the circulating virus,
Yes.
we would probably need to look at it from that point of view, that if we have to start vaccination, we should have vaccines which cover the circulating strain, which is currently Omicron sublineage.
So we could potentially have a yearly vaccination against COVID.
So in the future, it may be so that we may have a COVID vaccine which is like the influenza vaccine in terms of an annual vaccine.
Right.
There was also some studies which looked at whether it's possible to combine the two in one shot so that you could have an Omicron and influenza vaccine given as one shot. And studies suggested that if you gave both the vaccines to an individual, the immunogenicity of both the vaccines was maintained and there was no cross-reactivity. So it's possible that that may happen in the future.
Right. We'll come a little more to vaccinations, but I want to ask you, Dr. Laharia, are we in a position where we understand new variants of COVID better than we did when they were evolving and emerging? Given the fact that we have a brand new variant we're dealing with now, are we quicker and faster to understand what we're dealing with?
So much of the public discourse around a new variant or subvariant is determined by what WHO say. And for example, with JN.1, because WHO has designated it as variant of interest, so then people are concerned. But what we need to remember, the difference between the variant of interest and variant of concern. What variant of interest essentially means that this is something which we need to know more. So the governments need to monitor that variant of interest. And that's what the function of government says, that our public health agency that monitors something which could be potential threat. But when it is something like only when WHO say or when there is some like variant of interest does not mean that it is more severe or it is causing any other like major clinical change in the outcome. So variant of interest is government agencies and public health agency need to work on it. It becomes, people need not to worry about variant of interest. The variant of interest is alert for the health agency to do something. When it becomes variant of concern, probably that is the time when there is more required from the citizen and communities. Currently JN.1, what we know that this is a subvariant of what was circulating earlier called Perola. But what we also need to remember in the last 4 years, there have been only 5 variants of concern. And the last variant of concern was Omicron. Which was there in first reported in November 2021. So for the last 2 years, we do not have any variant of concern. Of course, the changes or subvariant of viruses would keep coming. This SARS-CoV-2 will keep coming. The agency need to monitor. Dr. Soumya also highlighted that pandemic is over, the emergency is over, but the public health challenge is not over. So that's what it is. I do not think that right now, it is getting a little too much of attention, JN.1, and sometimes I'm asked the question, are we better prepared? And I say when we start counting that there are 21 JN.1 case as if it's a novel virus, I think we are not really doing good service. 4 years down the lane, our approach to pandemic should be more nuanced and more granular. There is no time to count the an absolute number of cases. And final point I want to flag that then people are saying, are we heading toward a wave? But I would like to flag that because it is designated as a variant of interest, that essentially means public health agency should step up the testing. And if you increase testing 5-fold, the number of cases will be reported 5-fold. So we should not be looking at the number, we should be looking at the proportion of cases which are being reported.
Also the severity, I think as people, that's something that concerns us. But I have to say you've answered about 5 questions that I would have followed up and asked you. I want to ask you, as someone who's at the helm of affairs in community medicine at the All India Institute, Dr. Mishra, when a variant of interest like JN1 emerges, what is the immediate response? Is our immediate response better than what it was? Is it still knee-jerk because we were still learning about the pandemic, or do you think that we've taken stock of a situation and come whatever variant of interest or concern, we have our ducks in a row?
Good question. What I would say that when the COVID-19 first time came to India in 2020 January and then March, Since then, we have learned a lot of lessons about this thing. At that time, disease was pretty new. As Dr. Laharia has pointed out about this new strain, we should be, careful. But there's no need for panic. We have learned a lot from this pandemic. India is a huge country, right? And at that time, Dr. Guleria was heading this drive when the COVID was there. He was in AIIMS at that time. And at that time, we have learned a lot of lessons, especially in a country like India, where 70% of the population who lives in the rural area, right? So how to provide services to them, how to communicate to them. So the important thing here is the risk communication. That is very important. If you do not have a proper strategy for risk communication, there would be a lot of rumors, whether it is the new variant, it is the old variant, and there would be many more variants which would come. So important thing is, when you are communicating risk to the public, there should be reliable source, that is from the reliable media, reliable agencies. What we have seen during the pandemic, there are a lot of misinformation, whether it is related with the vaccination, it is related with the other issues. So risk communication is very important when we look at from the public health point of view. The other thing is very important is the surveillance. Surveillance activity is very important for any pandemic. I'm here not talking about the particular strain, but for any pandemic, surveillance is very important. And at the time of COVID, what we have learned, that we can have these services with the grassroots level worker. At that time, all the ANM, all the ASHA, Anganwadi workers, they were involved in the surveillance system. They have been brought, because otherwise it's impossible in a country like India. So if we give more focus to their training and ask them to continue to do surveillance activity, probably we will catch any pandemic, whatsoever it is, at the appropriate time.
It's very important that you say we'll catch it at an appropriate time, because Dr. Swaminathan, I think when we talk about preparation for dealing with a future pandemic, the question that I have is very simple. After all of this, are we better prepared at preventing a pandemic?
So I think it will be very difficult to prevent an outbreak, but we should be able to prevent it from becoming a pandemic. And that really requires, I think what Dr. Mishra was saying, the surveillance has to be very good. And I know that now the government, and I've been talking to people in the ICMR, really putting in place an integrated surveillance, which is environment, animals and humans. Because we know that many of these viruses are going to jump from some animal species into human. We don't know which animal species, but we know some animal species like bats, for example, carry a very large number of coronaviruses. But coronaviruses are not the only virus family that can jump into humans. We have a host of at least 25 other viral families out there. And many of them are in the animal kingdom, and one mutation and it can jump to humans and cause disease. So I think the surveillance has to be not only the labs and things like that, but communities. We need to build, we heard about the Ashas, Anganwadi workers, but there are still many pockets in India where outbreaks of zoonotic diseases like brucellosis, like leptospirosis, even anthrax, of course cholera, are occurring. Now that, I think the test of our preparedness will be how quickly are we able to respond and prevent deaths, ideally both in animals and in humans. And if we are able to do that, then I think we can say that we have achieved a state of good preparedness. So I think not all states and not all parts of India, we can be confident now that we're at that level.
But when it comes to surveillance, I think we have to look at it twofold, because one is of course catching the virus, and the second is understanding the strain. Have we done better? I mean, and I'm talking about India specifically, in terms of identifying strains, identifying characteristics of strains, whether it's genome sequencing, whether it's equipping our labs further. Do you think that we've done enough, or do you think there's perhaps more that needs to be done in that space of understanding what we're dealing with?
So we've done a lot compared to where we were 4 years ago. So we have a network of labs now. We have much more sequencing capacity. There's been a lot more investment into sequencing, also into BSL-3 labs and things like that, where you can isolate some of these viruses. Of course, there's also another BSL-4 lab being built. But I think the crux of the matter is what sort of surveillance is done, what is going to be sequenced on a regular basis, how are we going to use that information for public health action? Because it's not an academic exercise. Surveillance is to be done so that public health action can be taken. Doesn't matter whether it's influenza or if it is scrubbed. I'll give you an example of when there used to be these encephalitis outbreaks in Gorakhpur, eastern UP, year after year, and we would have children dying and nobody knew what it was. Some people thought it was Japanese encephalitis, but despite vaccinations, this used to occur repeatedly till we did metagenomic studies. The ICMR collaborated with other institutes, put in place metagenomic surveillance and found that at least 40 to 50% of those were due to scrub typhus, an easily treatable infection. So in our country today, when somebody presents with fever, we do not have the either the ability or the intent actually to do a diagnostic workup. So I think we should reach a point where every primary health center can do a diagnostic workup. If somebody comes in, a child comes in with vomiting, high fever, headache, you're suspecting meningitis, encephalitis. Somebody comes in again with fever and a rash. So there could be different presentations. A woman comes in, with a genitourinary infection. On our diagnostic side, especially at the public health level, we are still, and most countries are lagging far behind what we are in terms of drugs or vaccines.
But as far as understanding COVID variants are concerned, you've had the advantage of looking at this from a global standpoint. Do you think that India has a lot to learn from the West? Because I remember as a journalist covering COVID, we often looked to WHO or to a Western certified medical agency to understand what we were dealing with, as opposed to getting that information from the government or from a government certified agency.
We don't need to look to the West. And the good example is Omicron. You know that it was detected in southern Africa by South African scientists. So it was in Namibia, in South Africa, and one other neighboring country. And within a matter of 2 weeks of the first cluster of cases, which were a little unusual, and so the doctors had thought something different about these symptoms, they alerted the genomic scientists who immediately sequenced, saw that it was very different from the previous variant, alerted WHO. So within 2 weeks, this thing went from being nothing to a variant of concern. Now, this was South Africans, done entirely in South African labs. It was nothing to do with the West. And in fact, when all the Western countries put sanctions on them, they immediately put trade and travel restrictions on these countries. They said that we have been more efficient than many of the high-income countries. No other country ever found a variant so rapidly. So I think that we all need to improve our capacities. It's how we act on these things, but it's also something that has global implications.
Yes.
And I think when we're talking about pandemics, we saw countries being punished unfairly sometimes because of these kind of restrictions. And this is why the pandemic accord or treaty that's being negotiated now at the WHO is going to be important, because each country, of course, has to do what they need to do. But for a pandemic, you need a global set of rules and mechanisms so that we can avoid the big inequities that we saw during the last pandemic.
Right. Dr. Guleria, Dr. Swaminathan talked about surveillance. How do we deal with enhanced surveillance, or how do we foster enhanced surveillance at a time when there is so much pandemic fatigue that has set in? I mean, nobody is getting themselves tested for a fever. Like she said, we don't do that blood workup. We don't do it at the primary health level, and we don't do it even in the urban centers.
So I think surveillance is very important if you want to look for any outbreak. And 2 or 3 things are important. One is surveillance when you are looking at something which is abnormal, but then also having a backup of the epidemiological data to link that with what is it meaning in terms of increasing cases, increasing deaths, or different manifestation. The other important thing is that in a period like what we are right now, where you are having a number of cases of new variants coming up, because you will have new variants of COVID-19 coming up every few months. The importance of surveillance would be not only in terms of picking up clusters, but also doing surveillance which are hospital-based. Are hospitals seeing more patients with viral pneumonias, flu-like symptoms? Are we seeing more ICU admissions? That also needs to, that's easier to do, and that is something which will give you an idea that this variant is a variant of concern which is causing more severe infection, and that is what our concern is. You will continue to have small ups and downs in number of cases as far as COVID is concerned, with the new variants, because it will have an immune escape mechanism, it will become more transmissible, and you will have a lot of flu-like syndrome. And that could be because of COVID, it could be because of influenza, it could be because of other respiratory viruses. But if that translates into something which leads to more admissions, more deaths, then it's something that we need to be concerned. So if we need to do limited surveillance, I think we should do a sentinel surveillance which is more hospital-based, or have your ground workers looking out for some abnormality in terms of a cluster or some atypical manifestation where you can have a rapid response team going there and then checking it out to see is there something new happening.
Dr. Lahiriya, do you agree? Do you think we'll be able to catch a pandemic early, like Dr. Swaminathan said, in order to prevent it from becoming a pandemic? Do you think we have what it takes at the ground level to be able to do that?
I think yes, but let me elaborate a little bit on this one.
There's a health warning with that. I can sense it in your yes.
Well, we definitely are better prepared in many senses. Definitely there is genomic sequencing capacity, surveillance capacity much stronger. There is a trained workforce. But there is a caveat. The caveat is that this surveillance, disease surveillance is a health system function. So if you have a strong health system, you can identify the disease. That's what happens. So in the COVID-19 pandemic, every single Indian state has a better or greater capacity than before the pandemic. But the point is, the states which already had a greater capacity, Kerala, Tamil Nadu, and some other Indian state, have a far greater capacity now, and the state which had a poorer capacity still have a poorer capacity. So the gap between the states is still the same, and that is where the challenge is. So I would say that yes, we would be able to detect better than earlier, but the challenge is that capacity continue to remain suboptimal.
Right.
I also want to flag two quick points rather, that that's what I have been talking repeatedly, that the pandemic or any outbreak or epidemic, we should not stop when the cases stop being reported. We should learn the lessons from then, and then only the real success of those measures is. And final point is that like in India, we probably forget very quickly, and like once the COVID-19 pandemic was declared over, like we are not paying much of the attention, and now we all of a sudden are doing this thing. And final point is that misinformation, like we still are not dealing, like a broader lessons for entire health system about how to communicate science, and that is one area which is still we want more to be done.
Well, I have to say that as far as communicating science is concerned, I think you all have really shown the way, because your interviews or what you've written and what you've said, especially during a COVID-19 pandemic when none of us knew what we were dealing with, has I think helped a lot of us. But Dr. Swaminathan, I know you have a flight to catch, so I'll quickly ask you two questions before you go. One on the vaccine story. You know what Dr. Guleria said, and he said this in the past in several interviews as well, the fact that we need to move towards a more sustainable vaccination program as far as COVID-19 is concerned. Where are we at as far as that is concerned? Is there going to be a global vaccine for COVID-19, a yearly vaccine, or integrated with the flu vaccine? How do you see this vaccine story playing out in the context of COVID?
So I think there are two aspects here, and Dr. Guleria referred to both of them. The first one is to figure out when our immunity is going to wane enough that we are going to need a booster shot. And every country is different in terms of the vaccines that were used, in terms of the population profile, in terms of the infections that are. So I think for India, we have to generate that data. We have cohorts that are being followed up. And so over a period of time, we should be able to figure out if the vaccine immunity is waning, and particularly in the vulnerable groups like the elderly, and then decide on a revaccination program. The other thing we have to look at is the vaccine design itself. And again, Dr. Guleria mentioned that many companies are trying to do combined vaccines now for flu and COVID, for flu, RSV, and COVID, and particularly using the mRNA technology. And we could also try and make vaccines which are updated. So the WHO does have a committee which advises on what is the best strain that could be. For influenza, this has been done for many years.
Yes.
Every year the WHO recommends a northern hemisphere and a southern hemisphere flu strains. For COVID, it hasn't been that systematic, but it's also relatively new. Infection. So I think over time, we may reach the situation where there is an updated. Of course, we are always lagging behind, because once you detect a variant, it will take 6 months to develop a vaccine on that strain. And so maybe over time we'll be able to predict what we need. So I think our vaccine capacity and capability has also improved dramatically. And not only that, the R&D into vaccine design has tremendously improved, plus these new technologies that we've now learned, like about the mRNA, but there are others as well. I think if we invest more, not only in vaccine design, but also in delivery systems, for example, a nasal vaccine, a spray, would be much easier to go out and do mass vaccination than having to do injections. And some of our companies are making nasal vaccines. So we should be investing more into the innovation on that side as well.
And what about vaccine for children?
You mean for COVID?
For COVID, because we still don't have a vaccine for children under the age of 5 for COVID.
So that's another area where I think we need more innovation. And again, can we combine it with, luckily the children have fared relatively better. We've not urgently needed a vaccine in the very young age group. But it's always good, again, good to be prepared.
Could we potentially be looking at a one world, one vaccine situation as far as COVID is concerned in the future? Or do you think it's still going to be, each country doing different technology vaccines as we've seen through the course of the pandemic?
Well, I think one of the things that happened during the pandemic is that many parts of the world realized that they did not have capacity to do their own drugs or their own vaccines. So the whole of the African continent has no vaccine manufacturing. And so definitely those countries are now putting in great efforts to build that capacity. And I think some of the Indian companies are also helping them. But as far as India is concerned, we don't have a problem. We have excellent, vaccine industry. They supply the whole world.
Yes.
But again, I think there's an opportunity now to use some of the knowledge we gained, not just on mRNA technology, but also on virus immunology and about viruses in general, the amount of research that was done and the kind of tools. Today we have artificial intelligence that can actually predict the next, it can even discover drugs. So I think if we invest in creating data sets and make it available, then we can use tools like AI maybe to even predict which variant might show up and what kind of vaccine we might want to make for that one.
That's very interesting. This is a question that I actually want to ask each one of you. And I think if you look at the success and failure as far as the India COVID story is concerned or our preparation for COVID is concerned, one of the big successes has been the proliferation of our COVID vaccine program to be able to manufacture, supply to the world and disseminate, the last mile connect as far as the COVID vaccine is concerned is something that's been really exemplary. What do you think has been the big failure? Or the big learning, if I can rephrase that?
No, for me, globally, I think sitting in WHO, the biggest failure and learning was the fact that we could not protect the vulnerable around the world at the way that we should have. We knew there was only limited supply of PPE, limited supply of oxygen, limited supply of masks, then limited supply of vaccines. If only we had shared it around the world, and we could have saved many doctors, nurses, as well as elderly people and others who died. So our goal should be, first of all, to save lives. That applies to our own country. It also applies globally. So I think when we think about what systems are we trying to strengthen, let us try and save lives, especially wherever it is avoidable and preventable. And so if we gear up our health systems towards that, and we gear up our industry towards producing the kind of products we need for our own public health purpose, and I'm talking beyond COVID as well here. We need a TB vaccine urgently. I wish that we could all come together and really invest, because TB, India has the largest number of cases, largest number of deaths, and India also has a capacity to solve that problem.
Yes.
And so we need to use our massive innovation ecosystem to solve such large public health challenges.
Right. Dr. Mishra, if I can ask you the same question. If you want to talk about preparation and you want to talk about the future, it's important to look at the past and know what we did wrong so that we can get it right the next time. What according to you did we get absolutely wrong and we can do better?
Let me put this in a way, how we managed. First of all, we should learn how we manage this pandemic and what we have learned and where was the failure from which, our learning can be used for the future. When the pandemic arrived, there was a lot of panic So I have just told the risk communication is very important when you are dealing with the public, right? So there was a panic. The other thing is, if you see a lot of people, they were running to the tertiary care hospitals. They were going to the big hospitals, while a lot of cases could have been treated at the primary and secondary care level.
So that put more pressure on the bigger hospitals.
Bigger hospital, because those hospitals should be reserved for the cases which really need those hospitals. 85% cases could have been treated at the primary and secondary care level. I am not saying that they were not utilized, but if you see in the rural areas, you see in the suburban areas, it is mainly the government hospitals which are catering to primary and secondary care level, whether be it the PSC, be it the CSC, be it the sub-district level hospital. So what I feel, there is a requirement for the strengthening of those hospital services for the masses. 70% population uses those kind of services. So number one is the risk communication. That is very important. So the public should understand from where they should get the information and where they should go. The other thing is strengthening of the primary and secondary care health system so that we can reduce the burden on the tertiary care hospitals. Like if everybody rushes to the AIIMS, right, then if they are going to treat the cases which can be treated at district hospital, then there is no use. I mean, the resources are limited. The third thing is what we have learned from this thing, and we have done really well in the other sectors. Say, for example, when it started, we were not manufacturing any PPE kits, right? But with the help of industry, with the help of technocrats, with the help of IITs and many other engineering institutions, within months, we were producing surplus PPE. We were not utilizing it for only our country, but even supporting other countries as well. The fourth thing is that we have vaccine, we have discussed enough, so I'll not go especially for the vaccine, but it's very important for the medicine and the pharmaceutical industry. What we have shown that we can produce enough medicines not only for India but for other countries. That is very important.
Yes.
And during emergency situation, patent doesn't work. So these drugs can be manufactured at other places. So that is the lesson which we have learned during whether it's manufacturing. So I have. They have one or two more points. If I'll get time, I'll elaborate later on. I think
I'll come back to you. But Dr. Guleria, before I do this whole post-mortem, I want to ask you a very specific question. You came on several shows and we talked about several different treatments for COVID. So there was a lot of controversy around whether ivermectin, for instance, is good in the treatment of COVID. Should it be used, steroids and use of excessive steroids or non-prescribed steroids. Are we any better at understanding what works as far as treating COVID-19 or COVID-19-like viruses is concerned? Because ultimately, I think we reached a point where we were just treating symptoms, unless, of course, it was a very severe comorbid case where, within the hospital, there were different drugs that have been tried. So for the lay person, dawai kaun si hai jo COVID ke liye kaam karti hai?
So I think when we had this pandemic, we were not sure how the virus would behave and what would be a good antiviral drug. So a lot of repurposed drugs were used, and we had hydroxychloroquine, ivermectin, even remdesivir is a repurposed drug. It was actually for treatment of Ebola. So at that point in time, when you have a new virus, you really don't know what is the correct or the effective antiviral drug. One thing that we did lag behind was that we worked very aggressively on the vaccine, but we were a little behind as far as the global community and scientists were concerned in developing a good antiviral drug which could be effective against the COVID virus. We now have oral antiviral drugs also, which are available in India also, which decrease or stop viral replication. But I think that we need to look at broad-based drugs which are effective against a family of viruses rather than one virus. Because if we are going to look at two things in treatment, one is the vaccine and the other is drugs, then we need to invest more in developing broad-based antiviral drugs which are able to be effective against even new strains which may emerge.
But do we have enough of those in the market right now?
We have drugs which are available against specific viruses. For example, now we have an antiviral against COVID-19. But if we have a new variant, will we have a broad-based antiviral drug which will be effective against that? I don't think we have that right now.
So I think we had molnupiravir, for instance. I think that's the drug you're referring to that was working against previous...
We had molnupiravir, we have Paxlovid, which is now available.
But we don't know if it will work against JN1, for instance.
So it should work against the COVID strain, COVID-19 sublineages also. It does work against that. But if you had a new novel virus, which came because of jumping species or by a process of what is known as genetic reassortment, that 2 or 3 viruses, like we had for H1N1 swine flu, that 2 or 3 influenza viruses got reassorted and a new novel virus emerged, which was different. Then you are in a...
So we still have miles to go as far as that broad-based antiviral is
Correct.
concerned.
We need to work on that.
So, I mean, what according to you, Doctor, was our biggest learning or our biggest failure from the COVID-19 pandemic?
So I think the biggest learning was that, I mean, we did very well, but I think we should understand that the world is becoming a village and there is a lot of encroachment on the environment. So if you look at the last 23 years, if you look at this century, we've had a large number of outbreaks. We talked of SARS, we talked of Zika, we've talked of MERS, we've talked of H1N1, and now we've had COVID-19. We've had 2 pandemics in this century. It means that we are seeing viruses jumping species and causing more and more illnesses in humans. We had outbreak of Nipah virus in the south.
Yes.
So therefore we need to understand, and that's why, as Dr. Swaminathan said, we need to look at the concept of One Health. But along with that, we need to understand that as pandemics happen, they will not respect any boundaries. And therefore, when we talk of surveillance, it has to be a global surveillance and a regional surveillance. Because in a matter of hours, you can travel from one place to the other and you can carry the virus with you. That's what happened as far as SARS was concerned. A person carried the virus from Hong Kong to Canada, and we had outbreak in Canada in 2003. So it's very important for us to remember that now with travel becoming so much, we have to be vigilant not only at a national level but at a global level.
Right.
The other thing, I think, if you want to ask me what did we, our vaccine program did very well. I remember at some point when we had these discussions, people said it will take decades for India to vaccinate the entire population, and we did that very well.
In months.
Yeah. The only challenge that I think we had was that we became a little sort of complacent after the first wave and when the vaccine came, and we did not respect the virus as much as we should. And we said in the first wave we had less than 1 lakh cases a day.
Yes.
We could manage that. The Delta wave changed it all. We had 4 lakh cases a day. There was a huge spike in the number of cases. We couldn't turn around our admissions so that we had more beds available.
Yes.
And there was this whole issue of oxygen requirements. So I think there was challenges at that point in time.
Right.
We should have anticipated those a little bit better.
Dr. Laharia, your assessment.
So in the hindsight, everyone is wiser. And let me first say where we could have done better. So I end on the positive note. So probably somewhere between January to March 2021, like we were little overconfident and complacent that probably we behaved as if pandemic is over, and that's the area where we could have done little better. Second area, I personally think that throughout the pandemic till the very end, we were not using the available data for decision making. I think there were many myths which were propagated just because the data was not either publicly available or analyzed properly, such as like India continued to keep schools closed while there was not enough evidence to argue that school could be open. There was a myth which was not evidence-based that third wave would affect children, and so we could have used data a little better. Of course, there are some positive sides.
So you're saying that this data was there, but we didn't use it better, we didn't know how to interpret it better.
I think data was there with different agencies. So of course, the hospital admission data was available with different agencies, Indian Council of Medical Research. There was data on the COVID-19 cases with Ministry of Health. Probably these data sources were not talking to each other. And it was, of course, the priority was saving lives. So probably it was not given the attention that analyzing and that data could also contribute to save lives. So it was not given the kind of importance. And that's a third challenge, I would say, that we always have an opportunity to rectify or correct errors. And we still, unfortunately, are not doing that. Probably we should have learned from the pandemic that we should use health data more proactively, nuanced way, and for health decision making. And this area which continue to have some gaps. Where we did better, I think I completely agree that the vaccine research and vaccine delivery, both we did really well.
Yes.
In fact, vaccine research, not only in India, across the world, leapfrogged by at least a decade. What could have been achieved otherwise in a decade or even longer could be achieved in 1 year. So vaccine research is one big success story. Also strengthening health system capacity building for genomic sequencing, strengthening BSL-3 or different type of laboratory, some government allocation for under various Ayushman Bharat health infrastructure missions. So all of those are a success story. But like many of us who work in health sector always wish for more. Dil mange more is what we want as an outcome from this pandemic.
I'll end on the note that I began in the book that you all have co-authored with Dr. Gagandeep Kang. Your book is titled Till We Win. So have we won or are we still to win?
The success would be when we derive the lessons from pandemic period and implement them on the ground. Then only we can say we will win.
So we haven't won yet. Dr. Guleria?
Yeah, so I think we are moving in that direction, but there is a lot to be done. And as was said, that we need to not forget the lessons that we've learned from the pandemic. Unfortunately, we have a short memory and we move forward. A lot of these lessons or a lot of things that we faced during the COVID pandemic, we also faced during the H1N1 pandemic, but we forgot about that. So I just hope that now when we had so many deaths in such a severe pandemic, we learn from this so that we are better prepared for any outbreak, for any pandemic in the future, and we have, let's say, an action plan in place, systems in place, and as was said, we have good data sharing so that we are able to pick things up earlier.
So I hope your next book is not on a pandemic, but either way, thank you all very much. This has been a very, very interesting conversation. I think coming in at a time when we really needed a lot of this perspective with the new variant that's been in the news. I have to say that, as far as our healthcare professionals are concerned, in immense gratitude and salute on behalf of everybody over here. You all have been frontline workers, you all have been warriors, and I think whatever we have to deal with in terms of a public health crisis, God forbid there is one, I know we are in the best hands possible. So thank you very, very much.